Greetings from Brazil. First of all, I want to thank IAPD for the opportunity of sharing our work. Our study is titled Association between Molar Incisor Hypomineralization and Enamel Hypoplasia. I'm Dr. Santos, the first author, and Dr. Fernandes and Dr. Solano are the co-authors. The research was performed at the State University of Rio Grande do Norte in Brazil. To highlight that I have no financial relationships to disclose concerning the content of this presentation or session. Well, developmental defects of enamel are abnormalities in enamel quality or quantity that affect tooth formation, hardness, and color. Different kinds of enamel defects may occur depending on which stage of enamel development the ameloblast has affected. But basically, DDE can produce hypoplasia and hypomineralization defects. Enamel hypoplasia is a quantity enamel defect that causes a reduction in enamel thickness. Clinically, the borders are most regular and smooth. On the other hand, one kind of hypomineralization defect has been studied to a great extent lately. I'm referring to molar incisor hypomineralization, MIH. So MIH produces a demarcated opacity affecting at least one permanent first molar and sometimes other teeth, especially incisors. Clinically, it presents an alteration in the translucence of the enamel with distinct borders with the edges of the unaffected enamel, and it can be white, yellow, or brown in color. There is no conclusive data in relation to the etiology of those defects, but amelogenesis is a process controlled by genetics. It is therefore reasonable to hypothesize that genetic variation could be associated with those developmental dental anomalies. There is an association pattern among several types of anomalies related to a genetic background, such as agenesis, microdontia, and tooth transposition. But there is nothing regarding MIH and hypoplasia so far. Thus, the aim of this study was to evaluate the association between MIH and enamel hypoplasia. This was a cross-sectional retrospective study, initially selected from orthodontic files of patients aged 9 to 18 years old. The sample calculation was performed, and the results showed that at least 53 orthodontic records were required in each group. The sample consisted of 415 orthodontic files divided in two groups. A group with MIH, composed of 142 records from patients with MIH, and a group without MIH, composed of 273 records from patients without MIH. Enamel hypoplasia was evaluated by means of panoramic radiographs and from images that were present in the files of each patient. The diagnosis of MIH was performed using the criteria proposed by the European Academy of Pediatric Dentistry. All patients diagnosed with MIH via their orthodontic files have undergone clinical examination to confirm the diagnosis. A statistical analysis was performed using the SPSS. T-squared test was performed for all analyses, and the level of significance considered was 5%. Groups were compatible regarding sex, and table 2 shows the difference between the groups for the presence of enamel hypoplasia. As we can see, there was an association between those enamel defects. The present study revealed the association between the presence of MIH and increased risk of developing enamel hypoplasia. This association reinforced the multi-factor idea of the etiology of enamel defects, emphasizing the genetic role in the occurrence of both conditions.